right, that is fine.
And we talk about medication. Levothyroxine is given to them on for life, and then it's safe in pregnancy. It's taken to on an empty stomach, and then yeah.
We spoke about levothyroxine, about which condition, please?
Hyperthyroidism, the medication given to them.
Okay, the hypothyroidism. Okay, all right. So that is fine. Okay. All right. We've been able to say something, okay, concerning the hyperparathyroidism and the hypo. So please, let's take note, okay. In hyperparathyroidism, we established that there's a secretion of what? The parathyroid gland, excess, okay. There's excess secretion of parathyroid gland. So these patients usually they have more of their calcium, okay. They have more calcium in their blood, okay. So there's hypercalcemia, there's hypophosphatemia, that is low phosphate, okay. That is what we established in the hyperparathyroidism, okay. Very good. And then the hypo, realize that one there is hypocalcemia and then high phosphate. Then we also established the fact that in both of them, there is something wrong with their bones. Okay, there is low bone density scan. Okay, so there are chances for what? For osteoporosis and then fractures. Okay, there are chances for osteoporosis and then fractures. Okay, right. So let's try as much as possible and then revisit the recording that it was sent into the page concerning the hyperparathyroidism and the hypoparathyroidism. Okay, let's try and then revisit the recordings. Okay, all right. So day in, day out, we are having new students joining us. Okay, day in, day out, we are having new students joining us. If you're a new student here, you are warmly welcome once again to USR and a little okay. Yeah, so we started the endocrine system. So I will encourage that if you missed any of them, try and revisit the recording that has been shared on the page, okay, from when we started, so that you can get everything concerning the endocrine system. Very good. Now today we are doing pheochromocytoma, okay. We are doing pheochromocytoma or pheochromocytoma, depending on how you can pronounce it. Okay, me, I pronounce it pheochromocytoma, okay, or pheochromocytoma. Very good. So that is the condition we are going to treat today, and then later, if we complete or we finish early, we continue with DM. Actually, this one is not really that broad, okay? It's not that broad, so we might finish early and continue with the DM. Okay. All right. Good. So when we say pheochromocytoma, I'm sure you've heard it before. Who has an idea about pheochromocytoma, please? Who has an idea about pheochromocytoma?
Sir, please, what I know is increased secretion of epinephrine and non-epinephrine. I think that's what I know.
Okay.
I also know that, hello.
Yeah, I'm listening.
I also know that it's an abnormality that is related to the adrenal, what do we call it? Adrenal medulla, right? And so with the release of epinephrine and norepinephrine, it usually raises the BP. So they usually have a problem with hypertension.
Okay. All right. Madam Nanekia, I saw your hand up. Nanekia Boateng.
They said what I was going to say.
Okay. All right, that is fine. So I think that is all we should know about pheochromocytoma. Okay. If we have this understanding alone, we've already completed the topic. Okay. So in pheochromocytoma, actually, let's build this foundation. Let's take note that the endocrine gland and the hormones that they produce catecholamines as well. That is the adrenalines and the noradrenalines, or epinephrine or norepinephrine. Okay. The adrenal gland naturally produces this hormone, the catecholamine. It produces it naturally. Okay. adrenal gland produces naturally. So, you know, these catecholamines do a lot of functions in the body. It helps in stress response. Okay, it helps us to respond to stress. It helps us in cardiovascular regulations, controlling your BP and all those stuff. These catecholamines does that job. Okay, so naturally they are being produced, or they are parts of the hormones being produced by the adrenal gland. Okay, now the adrenal gland, we have two sections of the adrenal gland. We have the adrenal cortex and the adrenal medulla. Okay, the adrenal cortex and the adrenal medulla. Now let's take note. Addison's disease and Cushing's syndrome affect the adrenal cortex. Okay, the Addison's disease and then the Cushing's syndrome affect the adrenal cortex, and then the fucomocytoma affects the adrenal medulla. Okay, that section of the adrenal gland. So let's take note. Now, what happens in fucomocytoma is what some of us just said earlier on. Okay, it is simply a situation, okay, whereby there is what, a tumor in the adrenal medulla of the adrenal gland. Okay, there's a tumor of the adrenal medulla of the adrenal gland, in adrenal gland, whereby there is excess production of these catecholamines. Okay, leading to hypertension, cardiovascular complications, and other symptoms. So just note that, you know, these catecholamines are already produced by the adrenal hormones. They are already produced by the adrenal hormones. But in fucomocytoma, there's a benign tumor of the adrenal medulla in the adrenal gland. Okay, so when this occurs, there is proliferation of what? Abnormal cells. Anytime you hear cancer, the first thing that comes to mind is what? Proliferation of what? Abnormal cells. Okay, whereby the cells, begins to become abnormal, but then it also grows in excess, right? So there's abnormal cells, the group of abnormal cells. So when these cells begins to grow, all these cells try to some way, somehow mimic the normal cells. Okay, so also they begin to produce the hormones that are already produced by the gland. Okay, so when there's a cancer or the tumor of the adrenal medulla, because there's increase of abnormal cells, and this abnormal cells is trying to mimic the normal cells, and there will be more production of these catecholamines, which is already produced by the adrenal gland. Okay, so there's going to increase in their size, right? So we are going to have excess of catecholamines, which is adrenalines and noradrenalines. Now let's take note. How does hypertension occur? These catecholamines are vasoconstrictors. Okay, they can constrict your blood vessels, they can constrict your arteries, they can constrict your veins, and increase your blood pressure. You get it? So when they are produced in excess, there is over vasoconstriction, or let me say, the rate or the extent to which we should achieve our vasoconstriction to regulate our BP, okay, is exaggerated. Okay, so we have an extreme form of vasoconstriction, and then this will severely lead to what? Hypertension, and then later there can be what? Cardiovascular complications. Okay, so fucomocytoma is simply a benign tumor, okay, of the adrenal medulla in the adrenal gland, whereby there's excess production of catecholamines. Example is the adrenaline or noradrenalines, and then this leads to excessive vasoconstriction and then therefore hypertension. Okay, yes, I'm sure we are all okay.
Yes, please.
Okay, all right. Good. So let's talk about some of the causes and risk factors of fucomocytoma. Okay, so the first risk factor, we have genetic mutations. Okay, and then the example is the VHL. Okay, VHL, which is a condition. Okay, and then usually it is occurs when there's a mutations in your genes. Okay, when there's a mutations there are several of them, but then I just decided to just bring this example. Okay, this one we call it the full meaning of VHL. Okay, is the von Hippel-Lindau disease. Okay, von Hippel-Lindau disease. Okay, it's a rare condition, genetic multisystem disorder, in which there is cancerous growth in part of the body. Okay, when there is excess growth of cancer, okay, in several parts of your body, due to genetic multisystem disorder, that one is what the von Hippel-Lindau disease. Okay, so when you get this condition as a human being, obviously several parts of your body will be affected, and it can affect your adrenal gland as well. Okay, so we have genetic mutations. So that is one risk factor for what? For pheochromocytoma. Then we have family history. That is if I mean, it has been consistent in your family. Your mother had it, your sister also had it, okay, and then it has extended to you. Now, let me say this in your NCLEX, okay. When they are asking you, anytime they are asking you questions with regards to, I think I saw this question. That's why I want to put this across, okay. When you see this question, and then they are asking you, which of the following family members? Let me put it that way so that I can express it very well. Which of the following relation with family members stands a higher risk for contracting their disease? Okay, so let's say in your family, which people in your family, okay, that if they have a disease, you also stand a higher chance of getting the same disease that they had. So one is your mother, okay. That one is your mother. I mean your parents. Then your first line siblings, okay, that is your sister, your brother, whom you follow in terms of birth, okay. For uncles, for nieces, for what do you call it, nephews, grandparents, for them, they are not really, if they have a condition, that doesn't mean you are going to get it. Usually it's your mother and your siblings. Okay, so please let's take note, okay. I saw that question somewhere, some other time. So it's usually it's your mother and then your siblings. These we call them the first line family risk factors, okay, for transmission of diseases. You get it. So aside these people, it is very, very rare I'm going to get a condition or disease from, let's say, an uncle or an auntie or whatever. Okay. So let's take note. So family history can also be a risk factor, of course, for pheochromocytoma. Then we
What
have,
about your father?
yes, I said they are all parts. They are your parents, okay? Your mother and your father are your parents. So they are all parts. These are the first line, yeah.
This is on the mother
Very
alone.
good. Okay. But I said parents, or I didn't.
So you say mother. You say mother and your siblings.
Oh,
You did say parent.
yeah,
Yes,
I
you
said,
did.
yes. All right. Anyway, that is it. Okay. All right, that's fine. So the next risk factor is the multiple endocrine neoplasia syndromes. This one I was talking about it the other time. We treated the parathyroid gland. Okay. This one too is a condition whereby there is scattered cancers in your endocrine system. Okay. The cancers are just scattered across every gland in the endocrine system. So your pituitary gland, your thyroid gland, your pineal gland, your parathyroid gland, they are all experiencing cancers. And when you are going to get this condition, whereby there is several neoplasms, okay, neoplasm is cancer, okay, when there's several cancers occurring over all your endocrine glands, it means that your adrenal gland is also going to be affected, and it can affect your adrenal medulla, leading to what? Leading to pheochromocytoma, okay. Very good. Then we have the last one, that is exposure to radiations. Okay, like X-rays, like CT scans, like MRIs. When you are exposed to them for a longer period of time, when you are exposed to CT scan, you are exposed to X-rays for a longer period of time, you are likely to get cancer. Okay, you are likely to get cancer. Because the rays, they are not, even when we are exposed to sunlight for a longer period of time, it's not good. You get it, because there's too much ultraviolet rays. Okay, too much ultraviolet rays. So when you are exposed to sunlight, it's not good. So because of this question, because of this point, I want to have a question. I want to ask a follow-up question on the exposure to radiations in relation to the sunlight and then the UV rays. Okay, so in our NCLEX, okay, in our NCLEX, when is the appropriate time for you to be exposed to sunlight, and when is the appropriate time for you not to be exposed to sunlight? I have seen this question several times. That is why I'm asking. And it's very, very good when it comes to, they usually ask these questions under insomnia, okay? Under insomnia, management for insomnia. Yes, Madam Sarah.
So early in the morning, around 6 to 8 a.m.
That is when you can expose the person to the sunlight. That's when you get the vitamin D.
Mhm. So after 8 a.m., you shouldn't expose.
Yes.
All right. Anybody with a different answer?
Hello.
Anybody with a different?
I know it's
Yeah.
from 10 a.m. to I think 4 or 3 p.m. or 4 p.m. That is the time that you are not supposed to expose the person to sunlight.
Very good. So it is 10 a.m. to 4 p.m. Okay. 10 a.m. to 4 p.m. So between 6 a.m., 7 a.m., 8 a.m., 9 a.m., 10 p.m. Sorry, 6 a.m., 7 a.m., 8 a.m., 9 a.m. Okay, up to 10 a.m., you can expose the patient to sunlight. But the moment you get to 10 a.m. to 4 p.m., okay, don't expose the patient to sunlight. You can't expose the patient to sunlight between 10 a.m. to 4 p.m. So after 4 p.m., the person can come out, okay, because at that time it's believed that. But someone was saying that in Ghana, it is 10 a.m. to 6 p.m. because sometimes even at 5 p.m. you have the sun still scorching very, very high. So with respect to the US, what we are learning, the English, okay, let's stick to that. It's 10 a.m. to what? To 4 p.m. And then with this window, you don't expose the patient to sunlight, okay, to prevent excess exposure to ultraviolet rays and then to also control with your sleep. Okay, very good. So the symptoms of pheochromocytoma. Okay, the symptoms of pheochromocytoma. Of course, one there's what? There's hypertension. Because there's excess release of what? Catecholamines. Because there's excess release of catecholamines, these catecholamines are, as we all know, or as we discussed earlier, they are what? Vasoconstrictors. Okay, they are vasoconstrictors. They constrict your vessels. Okay, very good. The adrenalines and non-adrenalines, they can constrict your blood vessels, increase cardiac output. Okay, so when this occurs, it can increase what? Hypertension. You get, because when your blood vessels are a bit narrowed, the pressure at which the heart used to pump the blood will have to increase as a way of compensating. So that will lead to what? Hypertension. Okay, so let's take note. So there is hypertension as a symptom of what? Pheochromocytoma. And let me see, in pheochromocytoma, hypertension is the priority. Please take note. In pheochromocytoma, hypertension is the priority. Is the priority. Hypertension is the priority. Let's take note. In pheochromocytoma, our focus or our main aim is to reduce the patient's BP. Okay. Very good. Two, we have tachycardia. Okay. We have tachycardia. Of course, when there is vasoconstrictions, blood vessels are being narrowed, obviously the heart will try to compensate, okay, just to force blood through the arteries and then the blood vessels, and then this can cause what? An increase in your pulse rate, okay, so you get tachycardia. Then there is what? Cardiac arrhythmias. Of course, even if you have tachycardia, you can get sinus tachycardia, okay, it's a cardiac arrhythmias, right? And then later, if the pulse keep on increasing and the heart keeps on what? Increasing the rate at which it's pumping the blood, it can lead to severe situations like atrial fibrillations. It can even lead to what do you call it? SVTs and all those, that supraventricular tachycardias and all those cardiac arrhythmias. Okay, so let's take note of that one too as well. Okay, then there is hyperglycemia. There is hyperglycemia. Why is there hyperglycemia in pheochromocytoma? The rationale is that when there's too much release of catecholamines, catecholamines causes resistance, or when there's too much release of the catecholamines, it causes resistance to insulin effectiveness, okay, or insulin function. So let's take note, okay. Sometimes in the catecholamines, they even binds to liver, the pancreas, and then the way it releases insulin to regulate sugar level is being impaired, okay. They are being impaired. So just know that catecholamines, in relation to hyperglycemia, catecholamines, when released in excess, can bind to receptors like the pancreas receptors, the liver, and then the rest. That helps in sugar regulation, and then suppress what? Suppress insulin function. So let's take note, okay? Catecholamine suppresses insulin function or causes resistance to how insulin should work effectively in the body. Therefore, it leaves the blood in there. It leaves the glucose in the system and leads to what? Hyperglycemia, okay? It leads to hyperglycemia. glycemia. So let's take note of that one too as well. Okay, very good. Now, please, I'm sure we are getting it. Hello.
Yes, please.
Okay. 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 So then the next what do you call it? Sign, or the next thing that we should know of when it comes to leukocytoma is hand is up, Madam Comfort, yes.
Yes, good evening. So,
Good evening.
can we relate that because of this receptors, the catecholamine binding with the pancreas receptor, that leads to hyperglycemia? So, is it relation in most patients having hypertension mostly get diabetes?
Please, can you repeat it?
I'm asking that we realize that most of our HPT patients who come to our hospitals, they have diabetes. So I'm relating it to it that, is it because the catecholamines binds with the pancreatic receptors that leads them to get the diabetes?
Exactly. That can be a contributing factor. Okay. It can be a contributing factor. Yes, of course. Yes.
Thank you.
Very, very good point. Okay, the very good point from there. Okay. So I think now we've got another reason why most patients with hypertension. In fact, there's a saying that in Ghana, they are brothers and sisters, right? Hypertension and then diabetes, they are brothers and sisters. The moment you get hypertension, likely you are going to get, what do you call it? You are going to get diabetes also high. Okay, so that is one reason why usually hypertension causes, or there's a relation between the two of them. Okay, good. Then another reason or another symptom is hypokalemia, low potassium. Okay, the normal potassium level is what, 3.5 to 5.0. In pheochromocytoma, you can get hypokalemia when there is too much production of when there's too much production of what, of catecholamines. Catecholamines have a way of also shifting your potassium from your blood into the cells. Okay, so let's take note. Catecholamine, example, the epinephrine, the adrenalines, the non-adrenalines. It usually stimulates what we call the beta-2 receptors. Okay, and when these beta-2 receptors are being stimulated, and it shifts it shifts potassium from the blood into the cells. So let's take note. The reason why you are getting hypokalemia in pheochromocytoma, okay, is that when there's excess use of catecholamines, these catecholamines will stimulate what we call the beta-2 adrenergic receptors, okay, the beta-2 adrenergic receptors. When these receptors are being stimulated, they shift potassium from the blood into the cells, leading to what? Hypokalemia. Okay, very good. Then we have headache. Of course, if you have hypertension, anytime that you talk about hypertension, headache comes into play. Okay, then you get headache, then palpitations because of the way the heart is just trying to pump the blood. Okay, there will palpitations, and then sweating and tremors can't be taken out. Anytime we think of hypertension, okay, patients begin to have now tremors. They begin to have sweating, the perspirations. There's also palpitations. Okay, simply because the patient, there's what we usually say that there is change in what, hemodynamic stability. Okay, there is change in hemodynamic stability. So there will be sweating, there will be palpitations, there's going to be tremors. Okay, so these are the key signs and symptoms of what? Pheochromocytoma. At least, if not anything, just remember hypertension, and then the rest of the symptoms will follow. Okay, once you remember hypertension, you know headache will follow, you know palpitation will follow, tremors will follow, and then cardiac arrhythmia is also going to follow. Okay, so that is that for the signs and symptoms. Very good. Now let's talk about the diagnostic investigation. So diagnostic investigation 1, we have the CT scan or MRI imaging. Okay, CT scan or MRI imaging. So usually the patient is being taken to the CT scan unit or the MRI unit for what? For imaging. So we take pictures of the adrenal gland to visualize how the adrenal gland looks like. Okay, we can take CT scan. We can even do ECG, okay, because of the cardiac arrhythmia that can result from the hypertension. Okay, you can do ECG, you can do CT scan, you can do MRI to visualize the glands, the adrenal glands very well, and rule out any sort of what? Cancer. Okay, Very good. The same thing, the second point, the functional imaging. An example is the MIB gene scan. Okay, that one too can be used to diagnose what pheochromocytoma, right? Then we have genetic testing. So if we realize that the thing has been occurring in family, okay, then we can do genetic testing to see whether maybe there's something wrong with the genes, whether produced by mother or produced by father. You get it to rule out what pheochromocytoma. So we can do genetic testing as well to help us diagnose what pheochromocytoma. Now let's talk about this test. Vanillomandelic acid test. Okay. It's vanillomandelic acid test. Vanillomandelic acid test. Let's take note of this test very, very well. Okay. Vanillomandelic acid test. Vanillomandelic acid test. Now, do you know how this test is done? In most instances, okay, they consider this test to rule out pheochromocytoma. In most instances, they consider this test to rule out pheochromocytoma in most instances. So let's take note. Okay. I have seen a couple of questions on pheochromocytoma, and then they brought this test. Okay. So let's take note there. Vanillomandelic acid test. Now, how do you test for this? So you are going to do a 24-hour urine collection. Okay, in this test, you do a 24-hour urine collection. Okay, so the patient will urinate and then for 24 hours. So after the 24 hours, they will combine all the urine. Okay, they will combine all the urine. When they combine all the urine, they will measure the volume of the urine. Okay, so when they measure the volume of the urine, they will pick just a small sample of that entire urine. Let's say 10 mils. Okay, you just pick 10 mils of the entire fluid or entire urine volume. Then within that 10 mils, they will preserve it for a while and then test for the presence of this vanillic acid in the urine. Okay, so you will do a 24-hour urine collection. After the collection is done, you combine or we take the full volume of the urine and then we take a small sample. Then we preserve it small. Then after the preservation is done, okay, we now test for the presence of what? The vanillomandelic acid in the urine. Okay, very good. Now, this is how the results should show. Okay, this is how the results should show. So normal results are the ones I have displayed here. In a newborn, it should be less than 1 milligram in 24 hours. Okay, in a newborn, it should be less than 1 milligram in 24 hours. In an infant, okay, and an infant, it should be less than 2 milligram in 24 hours. Okay, in an infant, it should be less than 2 milligram in 24 hours. An infant is between 0 to 12 months. Okay, 0 to 12 months. Newborn is 28 days. Okay, a newborn is 28 days. And then an infant is 0 to 12 months. So between 0 to 12 months, when we test for the presence of this vanillomandelic acid, it should be less than 2 milligram in 24 hours. Then a child should be less than 1 to 3 milligram in 24 hours. Okay, or should be between this, at least it should be less than 3 milligram. Let me say 3 milligram in 24 hours. An adolescent should be less than 5 milligram. Okay, at least you should start getting things like 4, 3 in what? In the adolescent. Okay, but an adult, it should be less than 6.8 per 24 hours. It should be less than 6.8 for an adult. Okay, if you're an adult, you are not an adolescent, that is above 19-year-old, you should be getting what? Less than 6.8 when we test for this acid in your urine. Okay, so let's take note. Anything above these values are abnormal values, and then this could prompt you, the RNs, and then the physician, that patient is suffering from what? Is suffering from pheochromocytoma. Once we realize that the presence of the vanillomandelic acid is very, very high and above any of these values in whether an infant, whether a child or adolescent, then we can suspect pheochromocytoma. Madam Anita.
So I wanted to know if the urine is taken, like we don't preserve the urine and we just take it from, like make the patient urinate. Does it affect the results?
Yes, it could affect. Even normal urine sampling, ideally we should put it on ice, okay, before we send it to the laboratory for the investigation to be carried out. Okay.
All right. Yeah.
Normal urine collection. Yes, you should put some ice around the container. Okay, before it's being sent into the what do you call it, the laboratory for the investigation to be carried out. Otherwise, it can affect the results. Okay. All
Sorry.
right. Yes,
But
Madam.
Aki,
Yes, Sister
please,
Kusua.
how is going to take an infant's urine?
Very good. I think.
The newborn rather, and to the infant.
Yeah, usually they use for, well, the newborns and the infant probably at that time they are using what? They'll be wearing pampers, okay, or diapers. So when they urinate or anything, it goes straight into what? Into the diapers. But there's one thing that you can do. Usually they squeeze, okay. You can squeeze, or place, once you see that there's a urine, okay. Once you see that there's a urine, you try to just squeeze any amount that you can get from the pampers. You just squeeze that one into a container and then you keep it, okay, so it has gotten to 24 hours. I think I saw some time ago, okay, I came across a chance on a particular question, and then they were, I think, measuring, they were trying to balance a urine intake and output for a baby like that, diapers, okay, and that was how they were trying to give the rationale. So you try to squeeze the pampers, okay, so the amount of urine that is collected in there will now fall into a container, okay, then you can store or you keep the urine, okay. All right. Yeah, I can see some hands up.
Hello.
Yeah.
Yeah. Hello.
Yes, one at a time, please. Yes.
Yeah. I don't know if I am right. I saw it somewhere that they usually use roller cottons inside the pampers. So when the cottons are absorbed with the urine, then they will now squeeze the urine to do this test.
Yes. Yeah. Very good. Yes. You can use that approach as well. Okay. You can use that approach as
Okay.
well.
Okay.
Yes.
Again,
Okay.
we have something like a catheter. There is a device like a catheter, a sterile catheter, small one. So for the females, there is some that is stuck to the vulva, and so they wear it inside the pamper. So when the baby urinates, it collects the urine, and then we can use it for the sample. So for the males, we insert into the urethra, and then it collects the urine and some are collected to a small container. So once the urine comes, it's collected into the sterile container, and then we use it.
Very good. All right. Thank you so much.
Aki, please,
Um,
please, about the putting the urine sample on ice. I want to find out, can it be put in the fridge too?
Yes. Yes. If you are talking about ice, then fridge is not a bad option. Okay. It's not a bad option. But then, one thing is that if some of these samples that we take for laboratory investigations, in as much as we are saying that we should keep eyes on it, we shouldn't leave it inside. Let's say even if you are going to put it in a fridge, you shouldn't leave it there for a longer period of time, because fridge, they have high or let me say an extreme temperature. Okay. Like an ice, you just put it around to preserve it. Okay, when you put around to preserve it, it's for a while, and then even ice, once the times keep elapsing, how cool the ice is begins to drop. Okay, which is fine for the specimen, but put it inside a fridge. If you are going to put it inside a fridge, then it should be for a while. If you keep it inside a fridge for a longer period of time, that one too will not be good for what? For the specimen, because it will be exposed to an extreme temperature for a longer period of time, which is not good. Okay.
okay. Hi. So my question is about the values. I see the less than signs here, but you said if the values are greater than these, then it's positive, right?
I said that if these
Yeah.
are normal values, okay,
Right.
these are normal values, yes. So once you
Right.
see any value above these values, then it means that
Okay.
you start thinking of pheochromocytoma.
Okay. So the less than signs there,
they don't represent anything.
So if, let me say, if you are a newborn, you should have
Right.
your, let me go over again, okay? If you are a newborn, you should have your,
Right.
hello? If you're a
Yeah, I can
newborn,
hear.
yes, if you're a newborn, you should have your, okay, so if I'm getting your question very well, if you're a newborn, you should have your acid test, okay, this acid test less than 1 milligram, meaning when it's 1 and above, then it means that there's a cause for concern. If you're an infant, it should be less than 2, yeah. Meaning if it's 2 and
Okay.
above, yes, it should be, it should be called for a concern. And then if
Okay.
you are a child, yeah, if you're a child, it should be between 1 to 3. Above, it should be less than 1 to like between 1 and 2. Okay, so 10 above could be Miss Luther, miss this.
Salema, we are doing. Oh, say, Papa, now we moving in a class for medical genetics.
Okay, all right. So when it's a child, it should be less than, that is 1 and 2. Okay, meaning 3 and above could signal pheochromocytoma. Same for the adolescent and same for the adult. Okay, it's the same.
Okay, got it. Thank you.
Welcome. You're welcome. All right. So these are some of the tests that we can do or run to diagnose pheochromo or cytoma. Okay, we can do to run or
Hello,
diagnose.
Bobaki.
Yes.
Yes, I wanted to find out newborns and this infants, they can suffer pheochromocytoma.
Yes, so they can.
Yes. Wow. Okay.
Yes. All right. Okay, that is why we have their test also.
Okay.
Just that it will be rare. Okay, it will be rare in an infant or what do you call it? A child. Usually, it's common in the adolescent and the adult. Okay.
Okay.
Yes. You're welcome. Please, I hope we can move on.
Yes, please.
Okay. All right. So, can you pardon me? Let me check. I don't know what is wrong. Good. All right. So let's talk about the treatment. Okay. All right. Let's talk about the treatment. So the first thing I'm talking about is what? Adrenal gland removal or adrenalectomy. Okay. Adrenalectomy. So we do this surgery to take off what? The adrenal gland. Of course, just as what we do in what? We do in breast cancer. Okay. When there's a breast cancer, we take off the what?
Hello, sorry
Yeah.
for the interruption. I can just see half of the slides, please.
Please, can you see my screen?
Yeah.
Yes, please.
Yes, you can.
It's just half
Yes,
that
we
is showing at
can.
my end.
Okay. Then please check from your end, okay? All right. So just as what we do in what breast cancer, we do in any other kind of cancers that we take off the cancerous tissues out or the cells out. The same thing goes into what adrenalectomy, okay? Or let me say in pheochromocytoma. When we realize that the adrenal gland is being cancerous, okay, and then cancer they can spread, okay? Cancers can spread. So even if it begins in the adrenal medulla, it can transfer to the adrenal cortex, and then the entire adrenal gland will be affected. So we do a surgery to take off the adrenal gland, and that one is what we call the adrenalectomy. Okay. So I just want to ask a question: if we take off the adrenal gland entirely, okay, I mean the whole gland has been taken off, what condition comes into mind?
Heart attack.
Hypothyroidism.
You said what?
Adrenal
Hypothyroidism.
gland.
Why hypothyroidism?
Addison. Oh, Addison's disease.
Addison. Addison's.
Addison's disease, because
Same
there will be no
disease.
production of Addison's disease, okay, because there will be no production of the adrenal hormone again, okay. So Addison's disease is what comes into mind. Please, let's take a note, okay. All right. So the moment this patient is, the moment we do this surgical procedure, adrenalectomy, and then we are suspecting Addison's disease, then what comes into mind again? This patient must be on steroids for life. The gland is no longer there to produce the hormone, okay? The gland is no longer there to produce the hormone. So we must find something to replace it. So they must be on steroids for life. They must be on steroids for life. Talking about steroids, what comes into mind? We are thinking about bleeding, we're thinking about infections, we're thinking about infections, so immune system suppression, okay? We are thinking about the fact that steroids should always be taken with food. You don't take steroids on an empty stomach, okay? It can cause what? It can cause gastrointestinal bleeding. We are thinking about of course, bleeding. So we should know our bleeding precautions when it comes to steroids. Steroids can cause what? Osteoporosis. Okay. So the moment we are thinking about steroids, we consider what? Our 4 risk precautions. Please, let's try always to remind ourselves on some of these key NCLEX interests anytime we're talking about some of these conditions. Okay. So that is that for the surgical procedure. Very good. Then the preoperative management, we should control the patient's BP. Okay. Of course, if there is hemodynamic instability, it is very difficult to do a surgical procedure. Okay. Because we don't want to cause any complication like death. Once there is high BPs and all this stuff, it should be controlled before the procedure. So we must give them alpha blockers like phenazobenzamine, okay, phenazobenzamine or propanolol, okay. This will control the pulse rate and then also control the blood pressure, okay. It will control the blood pressure so that the patient will be in a stable state for what? For the procedure. So please, let's take note of that, okay. Let's take note of that. Very good. It causes, you are giving them what? Phenazobenzamine or propanolol to help control their BPs before the surgical procedure. Very good. Then the next thing you should do is that always educate the patient. If you have fichromocytoma, never and ever massage your abdomen. You don't massage the abdomen in fichromocytoma. No. The rationale is that the moment you massage the abdomen, you can stimulate excess release of catecholamines from the adrenal medulla. Already, there's excess production of the catecholamines already. So when you go and stimulate it by massaging the abdomen, you are going to cause or you are going to worsen the case, right? You are going to worsen the case. So in fichromocytoma, we don't massage the abdomen, please. Okay, don't massage the abdomen. Very good. Then we can do chemotherapy. Of course, there's cancer, right? So we can do chemotherapy when, especially in malignant stages, okay, when now the cancer has spread everywhere and then there is serious malignancy, we can do what? We can do chemotherapy, okay. So we give the patient some drugs to help kill the cancer cells. Very good. I have a question in mind. Okay, this is just crossed my mind. So a patient with fichromocytoma on your ward, okay. Let's say you took up, okay, let me frame a nice question, okay. At 8:00 time, okay, you took up the ward as an RN from your charge nurse. And then you realize that one patient on your ward had fichromocytoma, okay, had fichromocytoma. Okay, 1% on your ward had fichromocytoma. At 8:15 p.m., the doctor scheduled for chemotherapy. So you started the chemotherapy and then it was underway, right? It was underway. When a patient starts chemotherapy, or no, let me put it this way. Patient started the chemotherapy, okay. Then at 10 o'clock p.m., you realize that there is changes in the patient phosphate level, changes in the patient potassium level. So there is changes in the patient potassium level, change in the patient calcium level. There's increase in uric acid. There's changes in the patient phosphate level. What condition comes into mind?
Tumor lysis syndrome.
Very good. So tumor lysis syndrome. Okay. Tumor lysis syndrome. The moment we suspect some of these changes, when we started on a cancer treatment, the first treatment the first condition that comes into mind is what? Tumor lysis syndrome. Please, are you on the same page?
Please come again.
Yes.
Hello.
Hi. Please come
Hello.
again on that.
Are we
Hello,
okay?
yeah. Yes.
Okay, so when you start on cancer treatment, okay, let's say chemotherapy, and then there's changes in your phosphate level, changes in your calcium level, and then there's excess production of uric acid. We call that situation what? A tumor lysis syndrome. Okay, maybe one of these days we will treat it. Okay, we will treat that topic so that we will. That is not the focus today. Okay, but then I just want you to know ahead of time. Okay, so that when you meet it somewhere, you know it very well. It is called a tumor lysis syndrome. Okay, tumor lysis syndrome. When you start the yeah.
Please have a question.
Yeah.
So mean in that case, with patients with pheochromocytoma, meaning can they lie on the prone position? Can they lie on the prone position?
Like prone position.
As you are saying, we shouldn't massage their abdomen. So
Yes, you can lie. Lying on the prone position does not necessarily massage the abdomen. No. Okay. Massaging, I mean, you are, pressing, you are like palpating. Let me put it that way. You're like palpating the abdomen. No. But they can lie prone. Okay. They can lie prone.
Okay. All right.
Yes. All right. Very good. Very good. Now, another question. I want to ask another question here. No. In which other condition? Okay, this condition. Let me give you a clue. It affects children. In which other condition do you also want to massage the abdomen? It occurs in children.
Nephroblastoma.
Nephroblastoma.
Wilms tumor.
Wilms tumor. Very good. Wilms tumor or nephroblastoma. Okay. Wilms tumor or nephroblastoma. That one, you don't massage the abdomen. Please, let's pick some of these things. So let's pick some of these things. Okay. Whilst we journey on. Okay. Me, I like to ask questions. So I like to ask questions, especially when we are treating some of these conditions, especially key and case areas. Okay. So that we remind ourselves daily on them, because those are the questions that will come. Okay. All right. So anytime a patient begins chemotherapy, what comes into mind? There's reduction in how the immune system was going to function. Okay. And then there's also what? Stomatitis. Okay. So there's going to be reduction in the immune system functioning. So anytime the patient starts on chemotherapy, you start thinking of what? Preventing what? Overcrowded areas. Start thinking of neutropenic precautions. Okay. Neutropenic precautions, avoiding overcrowded areas. Okay. You avoid overcrowded areas. You avoid neutropenic precautions. You don't, cohort this kind of patients with other individuals that are have their conditions highly infectious. No, you don't cohort some of these patients with them to prevent or to minimize the risk for infection. But then, the moment you start therapy, then you realize that the patient's probably the patient has been exposed and has been infected. Okay, very good. Then, secondly, chemotherapy can cause what? Oral ulcers, or let me say stomatitis, inflammation of what? Of the mouth. So there will be sores in your mouth. Okay, there can be oral ulcers in your mouth, and then the patient can find difficult to eat, can find difficult to even try to put something in their mouth. Okay, so that is another effect of what? of chemotherapy, right? So let's take note of that one, okay, as also a complication of starting chemotherapy, okay. So these are the major treatments for fibromyalgia. Okay, all right. It doesn't go. Okay, so the complications are here. Okay, so we have the complications. So the complications we have what? We have cardiovascular events like stroke and MI. Of course, if there is hypertension, excessive hypertension, we can't forget about CV or stroke. So this one we are suspecting what? Hemorrhagic stroke. Okay, we are suspecting hemorrhagic stroke. Okay, because of the high BP, we are suspecting hemorrhagic stroke. Okay, then we are talking about what? Hypertensive crisis. Yes, when you have your BP with systolic above 180, okay, 180, 190, 200, then you start thinking of what? Hypertensive crisis. So that is also a complication of what? Pheochromocytoma. And then you have cardiac failure. Of course, if you are getting stroke, you are getting MI, myocardial infarction. Then, yeah, in the long run, I mean, how the heart is going to function is going to be affected. Okay, imagine a situation whereby your heart is just pumping, pumping, and pumping, and then you're even getting arrhythmias like SVT, like atrial fibrillation. Obviously, there's going to be cardiac what? Failure in the long run. So that's the complication of what? Of pheochromocytoma. Then we have renal impairment. We all know how kidneys and then the heart are being connected. You know, anytime the heart pumps blood, there is a blood supply to the kidney. Okay, so anytime the heart is being malfunctioned, the kidney does not get enough blood flow to perform its function. So kidneys are somehow also related to the heart. Okay, anytime the heart is being affected, there will be no blood flow, okay, to the kidneys. And then when this occurs, how the kidney will also function will become impaired. So they can also get renal impairment or kidney failure as a complication of what? Pheochromocytoma. Then lastly, we have what? Metastasis. That is when the cancer spread throughout the entire what? The entire body. And then we have what? Malignancies. Then we can also see that there is also a complication of what? Pheochromocytoma. Okay, so that brings us to the end of pheochromocytoma. Please, any question, contribution, or subtraction or addition, please. Hello, and I'm Sarah. Yes.
Tell us what's
Yes,
like a
so
previous slide, the treatment.
Yes. Is that what? And I'm Sarah.
yes, so I think I've seen a question somewhere that they were asking how to manage pheochromocytoma in a calm and I think in a calm or quiet environment. So I was asking, what has that got to do with? Because looking at the signs and symptoms and other things, I didn't see anything like calm. I didn't see anything like maybe agitations or anything, irritability somewhere. So
Very
the
good.
answer gave we should treat them in a
Okay.
calm environment.
All right. All right. You do have to can someone answer here?
Yeah, I think it's because of the epinephrine and norepinephrine that are being released during stress hours. So like with a person with that kind of condition, we are saying that even with that type, the person is already facing a lot of those hormones. So keeping the person in a very quiet place will also help prevent any stress factors. You know, well, when you are stressed out, there are a lot of epinephrine that are being released. So when we nurse a patient in a calmer area, I think it will also help reduce the release of those hormones. That's what I
Very good.
think.
Okay. Yes, you are perfectly right. Okay. You know, anytime you are in a let me say, anytime you find yourself in an area whereby there is noise, there is, you are being stimulated. You're not being calm. Okay. Let's take note. Okay, when we're in a calm environment, there is understimulation. But the moment you find yourself in an environment where there's noise, things are moving here and there is stimulation, just automatically. And then let's take note. I said earlier on that catecholamines are being released to do what? Catecholamines are being released to respond to stress, okay, or to help us to respond to stress. Let's take note. Catecholamines are released to help us in stress response. So imagine a situation where you find yourself in, you are someone with fucomocytoma already. There's excess release of catecholamines, increasing your BP. Then you go to market, let's say macula market. You see how there's noise, how there's pushing, how there's here and there. Okay, we are moving here and there is noise, there's here. Obviously, there'll be release of catecholamines once again to respond to that stress you are going through over there. That will even worsen the case. Okay, so usually when you have fucomocytoma, we have to nurse you in a calm environment whereby there is what? Under stimulation. You are not going to be stimulated that much to further increase your BP. You don't want to further release any catecholamines that can have a severe impact on your BP. That is why they usually say that you don't go into what? In a high stimulated environment. Okay, please. All right. I'm sure you're okay. Please, any other question?
Please, is there something that they have to do with the BP?
Yes, I said it right. You have to control the patient's blood pressure. Of course, once there's BP, you must always try to bring the BP down. So as part of the management is even what we just spoke about, nursing them in a calm environment, okay? Then I spoke about giving them what? Beta blockers, then giving them alpha what? Adrenergic, like the phenazole. Let me even bring that drug back. The phenazobenzimine, this drug, okay? You can give them all these drugs to reduce their BPs, okay? Then you must also give them antihypertensives, okay? You can also give them antihypertensive. You have to remove tight clothing, make sure the patient is free. Anything that will stimulate the patient, no, don't. Anything that will cause further stress response, don't do them, okay? So the patient should be calm. You give your antihypertensives, you are giving your phenazobenzimines, okay? You are giving antihypertensive. Yeah. So this management also goes in to reduce the patient's blood pressure. Okay. Yes. Any other question, additions, subtractions? Okay. Since you are okay, I have some questions attached to this presentation. Okay, or let me say attached to this topic. So let's read them and answer them. Okay. All right. Someone who can read for us. Who will read for us?
A patient is diagnosed with pheochromocytoma. From your nursing knowledge, you know that the patient will present with hypertension, sweating, and palpitations due to excessive catecholamines production from the A, adrenal cortex, B, adrenal zonal fasciculator, C, adrenal medulla, D, adrenal glomerulosa.
All right. So which answer are you going for?
C.
Now medulla.
C.
Okay.
You
All
said
right. So
C.
yes. So I said C. All right. So this one is very, very easy. Okay, very, very easy. So the answer is C. The adrenal medulla secretes catecholamines. Okay. So obviously the answer is C, which we spoke about. Right. Let's look at this topic. This answer is easy. No other explanation again. Let's look at the next question. Yes, who will read for us? Madam Sylvia, can you read for us? Madam Sylvia, Kwashi, are you there? Hey, nobody wants to talk.
A patient has excessive catecholamines in the urine. Which of the following signs and symptoms would the patient not exhibit? Select all that apply.
Very
A,
good. Please.
tachycardia.
Okay, you finish. You finish, okay?
B, anxiety.
C, hypoglycemia. D, thermogenesis. E, decreased basal metabolic rate.
All right, good. Please, the question, let's look at where the focus is. Okay, the focus is which of the signs would the patient not exhibit, not. All right, so let's pick our answers. Hello. Hey, no answer. Okay, let me see the chat.
C and E. C and D.
I'll go for C and D.
C and D. Some people are saying C and E. Some people to say D and E. C, E, D.
C and
C, D.
C and E.
C and E. Okay.
CE.
Okay. CE. Okay. Hypoglycemia, thermogenesis, decreased basal metabolic rate. Okay. All right. Let's look at the answer. So the answer is between C, D, and E, right? Let's look at it.
Yes.
So the answer is C and E. Okay. C and E. So the patient would have hyperglycemia, not hypo. Right. So we see it here. So the patient will have hypo, not hyper, not hypo. So that one is expected. Okay. And increase basal metabolic rate, not decrease basal metabolic rate. Okay. So those who are picking the D, why? Any rationale? Any rationale? Hello. Oh,
Hello.
we're just picking it. Oh, yeah. Please.
Okay, Martin, I didn't choose D because I didn't actually know what it is. Though I know what thermo means, like heat, something for me, but thermogenesis, I don't know whether production of heat or what. But I wasn't too sure of that. So that's why I choose C, hypoglycemia, because it's supposed to be hyperglycemia. And then the decrease basal metabolic rate, which is supposed to be this increase.
Okay. All right. Okay. All right, that is fine. So when we see thermogenesis, how do I even put it? Okay. So anytime you are exposed to, let me say, cold temperatures, okay. Let me say, anytime there is thermogenesis, simply the generation of heat. Okay. It's simply the generation of heat. And then catecholamines do affect that. Okay. Catecholamines also helps to generate heat, especially when you are in cold temperatures. Okay. Especially when you are in cold temperatures. Or let me say, anytime you are on heat, whereby there is increase in your temperatures, okay. Usually there is what? There is thermogenesis. And then also thermogenesis, okay. One way or the other, when there is excess consumption and then breakdown of glucose and fat in your body, there can be also thermogenesis. So let's take note. When there's increase in metabolism, there's breakdown of excess, glucose and fat. All this can contribute to thermogenesis. Okay, and then I'm sure we all know how catecholamines affect your glucose levels. Okay, so that is why that answer was not part of the options. Okay. All right. All right, so let's look at this. Okay, a client is admitted to the ICU with suspected fibromyalgia. The client vital signs are temperature 37.5, blood pressure 200/100, heart rate of 110, beats per minute and respiration of 20. The client is sweating profusely and reports severe headache. Which prescription should the nurse implement first? Draw labs, give acetaminophen, place a fan, start nitroprusside. Yeah, let me check the chat box. Yes, any answer? Okay, someone is saying C. Place a fan on the client too. Yes, any other answer?
Start naproxen.
Okay,
IVT.
D. Okay, D. Any other answer, please? What are you going for? What are you going for? Hello.
Yes, I'll go for D.
D. All right. Why D? Why are you going for
Because of the
Because
high
it's
BP. Because the BP is 200 over 110. And then we know that nitroprusside is a vessel dilator. And then, so since there's no any airway disturbance, I'd rather go for the circulation, which is nitroprusside.
Right. Very good. So the answer is right. Okay, he's right. So the answer is D. And then as I said it there, I said that if you go
The
the focus
priority, you
is
said that priority should be hypertension, right?
exactly, yeah. And if you go
Yeah.
always the priority is BP. Okay. So you must give drugs that will bring the BP down as fast as possible. And the nitroprusside is a vasodilator. Yes. And then these catecholamines are constricting the blood vessels. So why don't we give the vasodilator to release the blood vessels to therefore correct the hypertension? Okay. So the answer is D. Okay. The answer to this question is D. Okay. Let me see. All right. So the answer is D. Okay. So hypertensive crisis put the patient at risk for stroke, and so has the highest priority for treatment. Nitroprusside, okay, is a vasodilator given via infusion and can be titrated to keep the BP within a desired parameter. Okay, all right. So let's look at the next question. Which nursing action would be appropriate to implement when a client has a diagnosis of pheochromocytoma? A, weigh the client. B, test the client's urine for glucose. C, monitor the blood pressure. D, palpate the skin to determine warmth.
C, monitor the blood pressure.
Blood pressure. Very good. C, of course. Catecholamines, so when we think catecholamine, we think what? Anytime you chance on a straightforward question, don't waste time. You just check it, click your answer and you move ahead. Okay. All right, so that is it. So the answer is C. Hypertension is the major symptom that is associated with pheochromocytoma. The blood pressure status is monitored by taking the client's pressure. Okay, glucosuria, weight loss, diet are also clinical manifestations, but hypertension is the major priority. Okay, all right. Maybe this will be our last question. Okay, maybe this will be our last question. A client with pheochromocytoma is scheduled for surgery and says to the nurse, I am not sure that the surgery is the best thing to do. What response by the nurse is appropriate? Okay, this one card is therapeutic communication. So let's pick the correct answer.
Yeah.
Hello. Yes, let me see the chat box.
D.
D. D. D. Hey, I heard someone saying C. You have concerns about surgical treatment for conditions to have the surgery. All right. So we are all going for D, right? All right. Let's see if we are right. Okay. Let's see if you're right. Okay, so the answer is D. You have concerns about the surgical treatment for your condition. So the answer can't be C. There's no reason to worry. No. You don't ignore patient feelings like that. Okay, interpretive communication, anytime a patient voice out something, I mean, he or she is feeling about, you don't switch focus from it, or you don't ignore. You tell the patient there's no reason to worry. The patient is worrying, okay, there's something, I mean, bothering the patient about the surgical procedure and all those stuff. So if you tell the patient not to worry, it's like you are trying to ignore the patient's feelings, okay? Always, you must consider their feelings and then their consent, okay? All right, so the answer is D. All right, so that is it. Hey, okay, we have another question. A client admitted with pheochromocytoma returns from the operating room after adrenalectomy. Very good. Which assessment is most concerning? Glucose 70, potassium 3.4, blood pressure 169/98, sodium 146. What answer are we picking?
Yeah.
C. Okay. I see C.
I will go for
and C. Okay, C. Everyone is saying C. Okay. C. Hey, someone say B. Sylvia Kwashi say B. Because of hypokalemia. It's not far from normal. Okay. All right, let's see the answer. So the answer is C, okay. All right, so we've been saying this all the time, okay. Leukocytoma is a tumor in adenoid medulla that produces catecholamines, and next of this catecholamine can cause hypertension, okay. So surgery alleviates the BP, okay. Surgery corrects the elevated blood pressure most of the time, okay. So electrolyte imbalances are not typically affected. Yes, someone has his hand up, Mr. Yusuf.
Okay, so my question is, let me say, considering the same question, where in the question they have given the BP to be 200, let's say more than this 160, and then after the surgery, the BP is now 169. With all these possible answers being the same, would answer still be C?
Okay, so you mean that prior to the surgery, the patient had a BP of 200, right? And after the surgery, the BP is still high. With the same option. Yes, of course. The answer probably will still be C, because after the surgery, we expect the BP to drop to normal range. So if the BP is still high, then we should still look out for another thing causing the BP to be still high. Okay. Once the surgery has been done, and then the BP, the organ has been taken off, we expect the BP to be well controlled. Now, so if you are still getting a higher BP, and that is why they're even giving this rationale. Okay, if you are still giving a higher BP, then it means that still there's something wrong somewhere. We have to look at that. Okay, because all these all these parameters are normal. Okay, it is true that potassium is 3.4, but then it is not far from normal. Sodium is 146, also not far from normal. Okay, so that one we can't really pay attention to that one as compared to the BP. Okay, all right.
I just have a question.
Yes.
Please, can you remind me how to easily convert the glucose level from the milligram per deciliter to millimole? Thank you.
Yeah, very good. I was going to talk about that one very well in the diabetes, okay, but since you brought it, let me just talk about it. Okay, so if you are converting from the milligram to to millimole per liter, from milligram per deciliter, okay, to millimole per liter, you divide by 18. Okay, you divide by 18. Let's take note. You divide by 18. From milligram per deciliter, 2 millimole per liter, divide by 18. And for millimole per liter to milligram per deciliter, multiply by 18. Are we
Thank
okay?
you. Yes.
Yes. Yes. If someone has even sent it in the chat box. Okay, so when you are converting from milligram per deciliter to where? To millimole per liter, divided by 18. When you are converting from millimole per liter to deciliter, yeah, you multiply by 18. So that is it. Okay. All right. So the answer to this question.
Can you use your red pen to write that for visual learning?
He said.
I said, can you use your red pen to write that for us? Again for visual learning.
Let me type it in the chat box, okay?
Okay.
Yes. Are we okay? I'm sure you've all gotten it. All right. Are we okay? Hello.
Yes, yes. Thank you.
Yes.
All right. Okay. All right. Good. So that brings us to the end of pheochromocytoma. We are treating diabetes mellitus, and this will be the last topic to be treated under the endocrine system. Okay. Under the endocrine system. All right. Can we proceed? Can we move on, please? Oh, you are
Yes,
tired?
please. Yes. Yes.
Don't get tired, though. All right. So when we hear diabetes, when we hear diabetes, there's a common condition. Most of us, no, I'll not even say most. All of us here know about diabetes. Okay, all of us here know about diabetes. We all know about diabetes. So diabetes is a common condition that we all know about. Right. Good. So we say diabetes mellitus is a chronic metabolic disorder characterized by high glucose or high blood glucose levels, okay, due to impaired insulin secretion, insulin resistance, or both of them, okay. It's a chronic metabolic disorder characterized by Madam Nanakia. Madam Nanakia, please mute up. It's a chronic metabolic disorder characterized by high blood glucose level, okay, due to impaired insulin secretion, insulin resistance, or both of them. Okay. Well, let me give this as a preamble. Okay. How I usually do to understand diabetes very easy. Okay. So please let's listen. Okay. Right. So we have cells. We have some cells in your pancreas. Okay. We have some cells in your pancreas. We have the alpha cells and the beta cells. Okay, please let's listen very carefully. Okay, we have the alpha cells and then the beta cells. Now, primarily, these cells are responsible for sugar control. Okay, primarily, these cells are responsible for sugar control. Very good. Now, when you eat, anytime you eat, okay, anytime you eat, there is increase in glucose in your blood because there will be metabolism, okay? I remember our GHS, our primary definition for digestion. Digestion is a breakdown of food substances into blah, 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 okay? So the moment you eat, there's a breakdown. Now, when there's a breakdown, there's absorption, okay? So now, when everything is being absorbed, then the byproduct of the food you eat, some become glucose. So now the glucose are in your blood for energy. See, if you can run, if you can walk, it simply means that you have glucose. Okay. And so those of us here who partook in athletics way back in SHS school, okay, you realize that when you are running and then you are getting tired, you get glucose artificial and then take it. Because glucose primarily is for energy. If you can do anything, it's only because you have what? Enough glucose. Okay. I'm just giving a foundation of diabetes. You just have enough glucose. Now, one thing is that the glucose are not needed or it's not needed in the blood. No. The glucose is not needed in the, or let me say, you don't need, let me put it this way. You don't need excess of the glucose in the blood, okay? You don't need excess of the glucose in your blood. Anytime you eat and there is breakdown, and now these substances are being transported to your blood, it should leave your blood into the cells for energy. Please take note. Once you understand this, diabetes is conquered, okay? When you eat and there's increase in sugar levels, right? The sugar should be in your blood for some time, okay? But then insulin must be released by the beta cells, okay, of your pancreas. When the insulin are being released by the beta cells of your pancreas, this insulin will push the sugar or the glucose from your blood into the cells. So in a situation whereby there's something wrong with the person's pancreas, okay, or these beta cells is not being functioning properly, it means that when the glucose gets to the blood and then it keeps on increasing, there will be no glucose to transport what? To transport there will be no insulin, sorry. There will be no insulin to transport the glucose from your blood into the cells. Okay. Just imagine a situation whereby you want to travel. Okay. Wherever you are, wherever, let's say you're in your house. So your house, you being in your house simply means that, just take, for instance, you are the glucose, right? You are the glucose. And then your house is the blood. So if you are in your house, it means that there's glucose in the blood. You get it? So you're in your house. Now you want to go to, let's say, the bank. Now, before you can get to the bank, you must get a car to transport you from the bank to transport you from your house to the bank. Okay, you must get a car. So the car is the insulin. It is the car that will transport you. Let's say you order Uber. Okay, it is the car or the Uber driver who will transport you from your house to the bank, and then you achieve your goal of going to the bank. So in a situation whereby you order the Uber, then the driver is not coming early. There's a traffic, the driver is delaying. What happens? You stay in their house for long. So this is what happens in diabetes. When the glucose gets to the blood, and you're not getting the insulin to transport the glucose from your blood to the cells, it stays there forever. Then it keeps on increasing. Then we say there's what? High blood sugar level. Then we say there is what? Hyperglycemia in diabetes. Please, are we all okay? I'm sure this is okay. Okay. Very good.
Please, can you
now? Wow. Okay. All right. Let me see the chat box. Okay. Right. So I was saying that when you eat, the moment you eat, let's say this evening, you are going to eat, some of us are going to eat Indomie, some of us are going to eat Bangkun, rice, whatever, yeah. The moment you eat, there is release of glucose, because there's going to be metabolism. There's going to be metabolism breakdown, digestion will take place, and then there'll be a byproduct of whatever you ate. Okay. And then the moment you eat, usually glucose is, let me say, it's a byproduct of so many food substances. Okay. The moment you eat, usually glucose is a byproduct, because without glucose, you don't have energy. So usually when you eat after digestion, you have glucose. Very good. Now, these glucose are being transported, first of all, to the blood. Okay. Now, when you get to the blood, one thing you should know is that it shouldn't stay there forever. Some of the glucose should be transported from the blood to the cells for energy. Okay, some of the glucose should be transported from your blood to the cells for energy. So in a situation whereby there's something wrong with your beta cells of the pancreas, okay, where there is no production of insulin, because it's the work of the insulin to transport the glucose from the blood into the cells. So if the work of the insulin is not being achieved by transporting the glucose from the blood into the cells, it means that the glucose will be left in the blood. And when the glucose are being left in the blood, what occurs is what we say there is what? Hyperglycemia in diabetes mellitus. Okay, so you eat, there's glucose in your blood, it shouldn't be there. Insulin must be released. When insulin is being released, it must transport the glucose from the blood into the cells. But if something is wrong with your beta cells of the pancreas, it can't release the insulin. So the glucose will stay in your blood for a long time, and then this will lead to high blood glucose levels. And we say there's what? Diabetes. Are we all okay? Hello, are we okay?
Yeah.
Yes, sir. Yes,
All
please.
right. Very good. Then we have other aspects of the cells. We have the alpha cells. The alpha cells also secrete what we call glucagon. Okay. The alpha cells secrete what we call glucagon. Right. Now, when you eat, okay, when you wake up early in the morning, the first food we take is what? Breakfast, right? It's breakfast. So let's say you ate around 9 o'clock p.m. or let me say 8 p.m. From 8 p.m., you went to bed. From that time, you didn't eat till the next morning. And then you took your first, let's say, porridge or tea or oats. We say that one is what? Breakfast. It is assumed that, according to science, it is assumed that when you don't eat for 8 hours and more, you are fasting. Please take note. The moment you don't eat for 8 hours and more, it is assumed that you are fasting, according to science. Okay, so these alpha cells play a major role, especially at night. So let's say you're going to bed and you ate around 9 p.m. You ate something like, let's say, around 9 p.m. Throughout the whole night, okay, so you don't worry. When we are ending this topic, we will treat that confusing topic, the Somoji effect and the dawn phenomenon that has been confusing people all this while. We will try and settle it by the end of this class, okay? When you are not eating throughout the night, okay, it is presumed that you are, or assumed that you are fasting. So there's no glucose being released because you are fasting, you are not eating. Okay. So when you sleep at night, that is when the alpha cells also comes into play. The alpha cells must check and must make sure that there is enough production of glucagon to increase what? Your glucose level and prevent hypoglycemia. Okay, please don't get confused. When you eat, the moment you eat, there is release of what? Glucose in your blood. The glucose must be transported into your cells all the time. It means that when you don't eat, there will be limited production of what? Glucose, because you're not eating. So that is what happens when you are sleeping. When you are sleeping, nobody's eating when you are asleep. So for the period of like 9 a.m. to the next morning, like 9 p.m., the next one like 7 a.m., nobody's eating. So it's like 8-9 hours interval. At that time, you're not eating. So there'll be no production of glucose. Then the other cells will be released from the pancreas, and that is the alpha cells. When these cells are being released, they produce the glucagon. This glucagon will break down the stored glucose, that is the glycogen. Okay, it will break down the stored glucose in the form of energy. So that is when the patient begins to have enough of what? Enough of glucose when you are at night or when you are sleeping. Okay. So the reason why most of us we eat around 9 o'clock, okay, but nothing occurs to us in the night is because there's production of glucagon, and this glucagon is increasing your glucose level all the time. It's breaking down the glycogen, okay? It's breaking down the glycogen. So do you know if within the day, you didn't eat plenty, let's say you ate around 10 a.m. and that was all, you didn't eat well, or you didn't eat plenty, or for some time you've not been eating, the glucagon will try to break down stored glycogen to in a form of what? Energy, so that your body will have some kind of energy. And then also, that is when ketosis comes in or ketones comes in. The body will also try to break down stored energy in your stored fat. Let me put it that way, okay? The body also tries to break down stored fat, and that is when we get what? The ketosis or the ketones for energy. Now, when the body uses all this stored fat and stored energy, and then we say there is nothing left, then we say you are going to what? Hypoglycemia. Okay, when the body breaks down the stored glycogen, breaks down the stored fat into ketones, breaks down the stored glycogen to glucose, and then it has used all the stored substances. Okay, it has finished, and nothing is left. You are not eating, so there's no glucose again to be stored later. Then we see the patient is running to what? Hypoglycemia. Okay, please, are you okay with these explanations? Ali, we should understand hypoglycemia, and
Yeah,
DM.
please, I want to ask a question.
Okay.
So, looking at how you've explained the glucagon and then the other things, where from there, you see, there is, I don't know how to call it, but they have been saying something like inkiti, something like when you don't eat during the midnight.
It's hypoglycemia.
So why does it come that fast? Because since there is ketosis and whatever, it means that we are taking glucose from other, like the adipose tissues and other things. How does it come so fast for the person to go into hypoglycemia?
Yeah, so I think I said it. When you don't eat a lot in the day, please take note. When you don't eat a lot in a day, there's little glucose left. Or let me say, after the glucose has been used for the cells, the rest that has been stored, like the glycogen, it will be small because you didn't eat a lot. Okay, or for some time you will not be eating a lot. You get it? You will not be eating a lot. It means that this patient, because the patient has not been eating a lot, because the patient has not been, having enough energy, eating more or high caloric diet to sustain the person. The moment you get to the night, and then the glucagon starts using the stored glycogen, and then it is finished. When they use the glycogen and then it is left with little or it's not enough, then it's when the hypoglycemia will start setting in. Okay, very good. So if you think that you are that type of person that you don't eat during the night, try as much as possible, and at least your last meal should be around 4 p.m. or let's say 5 p.m. At that time, the glucagon will have enough stored glycogen to sustain you throughout the night. Okay, will sustain you throughout throughout the night. Okay, but in a situation whereby you don't have enough of the stored glycogen, or presumably your body has used all the glucose for energy, so there's little left. You've engaged in, let's say, jogging or running a lot of the times, okay, and then you are not eating anything to replace the glucose. It means that your body will be left with little glycogen and little glucose to even work out later. This is where the hypoglycemia will start setting in at night. Okay. All right. All right, that is fine. Please, are you okay? This explanation should help us. It should be a foundation for us as we treat diabetes. Okay. Please, are you okay?
It's perfect.
Yeah.
All right. Very good. Very good. All right. So let's look at the types of diabetes. We have type 1 diabetes. In type 1, usually this one occurs in children, okay, and then young adults. This one, there's an autoimmune destruction of pancreatic beta cells, okay? So these cells are responsible for production of insulin, and then this insulin pushes the glucose from the blood into the cells for energy. So in a patient whereby there's autoimmune destruction, the body itself is destroying the pancreatic cells. The body itself is destroying the pancreatic cell. It means that there will be no production of insulin. So this patient will suffer from hyperglycemia, okay? And then later diabetes. Then you have type 2 diabetes. That one we say there is insulin resistance or impaired insulin secretion, often associated with obesity, physical inactivity, and then genetic predisposition. Okay, so in the type 2 diabetes, what we are seeing is that this one, the beta cells, nothing is really occurring to the beta cells. Okay, they are producing enough of the beta cells. Okay, they are producing enough of the beta cells and then enough of the insulin to really move or to really transport the glucose from the blood into the cells. But here lies the case, for some reasons like obesity or genetics, okay, there's a hindrance or there is an obstacle to the effectiveness of the insulin. So there's insulin resistance or secretion or impairment. So therefore, even though the insulin are being released to perform their functioning, they are not being able to achieve it because there's that kind of resistance, whether obesity, whether aging, or whether smoking alcohol. This has been a stampede against what? Against the insulin. Okay, very good. Then we have the gestational diabetes. That is diabetes developing during pregnancy, usually resolving after delivery. I think it takes the midwives over here. And I think it takes. I think it should be 12 weeks before the gestational diabetes should resolve, right? 12 weeks or 20 weeks. I think I will check it later. Okay. When you do this, when you have gestational diabetes, okay, it should be, I think, 12 weeks. And after delivery, after 12 weeks after delivery, it should be able to go. And then it is believed that if the 12 weeks elapse and then the diabetes is still there, it means it is with you forever. Okay. It is with you forever. And then the gestational diabetes, it comes about because of the several changes that occur. Several
It's 6 weeks or
6 weeks.
42 days. 42 days, which is equivalent to 6 weeks.
Oh, okay. Okay, I see. All right. Thanks for the correction. Okay. So because there's changes, there's a lot of hormonal changes, there's a lot of changes in the woman's body. This contributes or this in turn leads to what? Gestational diabetes. Okay, I have a question here. I want someone to just get this question. Okay. When we talk about gestational diabetes in NCLEX, right? And we say gestational diabetes, which maternal complication comes into mind first? Which, like, if you have been doing kill banks, you'll be studying, you should know this very easily. Okay. Or you've been coming across a lot of kill banks, a lot of questions on gestational diabetes. Which question comes into mind? NCLEX like that question very much. Hello. Oh, okay. Maybe you've not come across it.
Please
But
take
we are
the
done with
question again.
we are done with maternity, right? You should know. I said that when you are having gestational diabetes, okay, which complication usually comes into mind, or which complication is usually linked with this condition on the NCLEX?
Macrosomic babies.
Very good. Macrosomia, and then what? What does the macrosomia cause?
Fetal hypoglycemia.
Shoulder dystocia. Very good. But you are all right. Okay, you're all right. But I was looking for that particular condition. Usually on your ankle, saying they will link gestational diabetes with macrosomia and then later shoulder dystocia. Because if the baby is too big, it becomes easy for the baby to come out through the vagina. So usually their shoulders are being locked up in the mother's symphysis pubis, and that is what we call shoulder dystocia. Okay, shoulder dystocia. Very good. We are doing well. Okay, we are doing well. That is how we should be thinking. That is how the NCLEX is too. Trust me. So once you start reading, a patient with gestational diabetes, the mother is in labor, the baby is not coming out. Then you start thinking of gestational diabetes. Okay, start thinking around these things, the moment you are learning some of these conditions, okay. When you analyze questions like this, it becomes easy for you on the NCLEX. Okay.
Hello,
Right.
sir. Please, I didn't
Yes.
get the first condition. For the shoulder one, I got it, but the first one you said.
It's macrosomia. It's not even a condition. Let me say a big baby, okay, greater than 8 pounds. Okay. When you give birth to a baby and the baby is greater than 8 pounds, 8 pounds in kilogram is 3.6 and above. Okay. Or let me say how the baby was in utero, not even delivered. Okay. While the baby was in utero, we tried to get the baby's weight, and it was very, very high. That is greater than 8 pounds. It is you call it fetal macrosomia, and then it can lead to shoulder dystocia very easily. Okay. All right. Yes, Madam Vivian.
Okay, thank you. Please, I want to find out. So, can fasting can it affect diabetics positively or negatively, especially the type 2 diabetics?
Okay. Hey, someone is writing on my screen. Madam Lamisi, writing on my screen. So fasting, anytime you're fasting, let's say you are doing 6 to 6 fasting. Okay, so from 6 a.m., 6 p.m. you are fasting. Please, what you are doing is that, what is occurring is that for that period, for that 6 to 6 period, the body is still compensating by releasing more glucagon. Okay, the body is still compensating, releasing more glucagon to break down glycogen, and then fat deposits are also being broken down into ketones to be used by the body. It is still working. So usually when you're fasting, that is what goes on. Okay, that is what goes in our body, so that there will be no hypoglycemia. So anytime you are fasting, there is glucagon working effectively. That is when the glucagon begins to work effectively. Okay, very good. So in type 2 diabetes, okay, when there's a distraction, let's take note of. So to the question that someone even asked earlier, I think this one to answers it in addition to what I said previously. Okay, so if there's something wrong with your pancreas, it means that your glucagon will not be released by the alpha cells. That is when you can run into hypoglycemia very easily. If your pancreas, if you drink alcohol a lot, you drink alcohol a lot and your pancreas is being affected, and then the cells, all the cells there are being destroyed. It means that both the alpha cells and beta cells cannot be released. So if you are fasting, instead of the alpha cells releasing the glucagon to increase your sugar level a bit, there are no cells to do that work. Therefore, you are going to run into hypoglycemia very easily. So let's take note. Okay, let's take note. If there's something wrong with your alpha cells or there's something wrong with your pancreas, it means that the cells cannot function properly. So in the fasting period, you can run into hypoglycemia very easily. But then if it is functioning properly, usually the glucagon will increase the sugar level within that period so that there will be no hypoglycemia. But then if it continues, okay, if it continues, let's say 3 days fast and dry, no food, please, you are putting yourself into danger. Because at the point in time, the body will use up the stored glycogen, the stored glycogen, the stored the stored fats and all those stuff that you have been eating for previously. They are going to use all of those things. And when it is being used up, please, if it is being used up, then you are going to run into hypoglycemia, and then you are going to be in a serious situation. Okay. So if you are fasting, please be mindful of it. But then we know that fasting is a spiritual work, right? Being empowered by who? Our God. So well, by anyway, this is science. We are also learning science. Okay, so when you are fasting, just be cautious a bit. Please be cautious a bit about fasting so that you don't put yourself into danger. Okay. All right. So that is it. That is it. Please, I'm sure you're okay.
Yes, sir.
All right, that's fine. Okay, so I think our time is up. Okay, yes, our time is up. Our next topic, our next subtopic is the risk factors to diabetes mellitus. Okay, the risk factors, which will continue tomorrow. Okay, and then try and finish the diabetes tomorrow. Okay, all right. Please, any question, contribution, subtraction, addition?
Okay. Hello.
Yeah.
I wanted to ask a question about the NCLEX questions. Like, just as you said, you got simple questions. how does it come? Like, does it come like maybe the simple ones will come, then the difficult one, as in the case study, and then does it have to be like after the simple ones before the case study will continue, or it comes randomly?
It comes randomly. Okay, it comes randomly. Ideally, no, these days there has been a lot of changes. Okay, during our time, okay, last 3 years, last 3 years, you should, let's say if the computer cut at 85, okay, if the computer cut at 85, you are going to get only 4 case studies, only 4 case studies. But these days, people cut at 85 and they say they get case studies like 6. Okay, so these days you can't predict it. It's like they just throw it randomly. Okay, so just be prepared for everything. Okay, but then if you cross 85, unless you are going to 150, that one, be expecting more case studies. Okay, be expecting more case studies. Be expecting more case studies. Class was interesting. Okay, is that so?
Why?
He said,
why will you should expect more case study when you are getting
because
closer?
your number is increasing. You are extending beyond 85. So you should be getting more cases. You can get like 9 case studies or 8 case studies. Okay. Yeah. But as I'm saying, the English questions, we all know they are CAT, computer adaptive. So the computer checks your strength and brings the question. That is how the English is. The computer checks your strength and brings the question. Okay. So be prepared for everything, please. All right. That is it.
Please, will there be any instance where we will solve some of the case studies here?
The case study is sometimes we do those things. Okay. There are times whereby we do we just use one of our live class to do questions. So I'm sure we'll be doing those things as we go on. Okay. But then the best will be to get a kill bank. Okay. Try and get a kill bank. Once you get a kill bank, you'll be exposed to a lot of case studies so that you have a feel of them. Okay. Please. All right.
Hello.
Okay.
Hello.
Please,
So
let me add this.
when is it advisable to start skill banks, especially when you are using your the dashboard?
Okay. So when we advise that 2 months to your test, buy a Q bank. At that time, you've been on the dashboard, you've watched the videos, you've read a book for a while, so you have a little content to approach Q banks. Okay. So when we are 2 months into your studies, and then 2 months to your test day, you can now start using a Q bank. Okay. All right.
You don't necessarily need to finish up the dashboard first.
Oh, not really. But then it will be good if you finish the dashboard, because at that time you've completed all the case state, the contents. Okay. But then usually we advise that 2 months to your test, okay, or 2 months into the studies, where at least you've gotten enough of the content, you can start using Q-Bank, because the learning also continues with the Q-Banks. There are a lot of things you'll be exposed to when you start using the Q-Banks. Trust me. Okay. All right.
So please, will we get free Q banks, or we have to subscribe to all of them?
Yes, you have to buy them, please.
So you don't have free one?
No, the free one is what you use on the dashboard for now. Okay. Yes. But any other, you can buy any of the Q banks. Okay. But then currently, maybe I will advise or I will suggest. But then all Q banks are good. Please, all Q banks are good. Archer is good. Me, I used UWord. Okay, for my exams, I used UWord. But you can use bank boot camp. These days, boot camp is raining. Okay. These days it is the one that is raining anyway. But then any of them is good. Archer is perfect. UWord is perfect. These days I still like using UWord Qbank more than any other Qbank, because I like it. The rationales are good. Okay. So bootcamp is there, Next Achieve is there, Archer is there, bootcamp, UWord is there. So any of them you can buy them. Okay. All right. So that is
So
it.
please, so how is the case study like? Like, give me one example, please.
Okay. So the case study, I think I have been doing. Are you in our general page?
Yes, please.
I sometimes try to do those things in the general page. Okay. So the case study begins with history taking or history, right? Whereby, let's say this condition, fibromyxoma, okay. Let's say you have a 95-year-old male patient, and then they'll give you the history. Cardiovascular, there'll be hypertension, tachycardia, blah, 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 BP of 190, 100. They'll go to respiratory, everything is fine. They'll go to genitourinary, everything is fine. Okay. Then they will bring a diagnostic test. So you go to the diagnostic investigations, then you check there as part of the history, you realize that there's increase in vanilla mandelic acid test of around 10.5 in an adult. Then you mean, okay, then let me start suspecting what? Pheochromocytoma. Okay. Once you see those things, start suspecting pheochromocytoma, right? Then the options will come. Based on the diagnostic investigation, based on the history, which condition would the iron anticipate? Okay. So you anticipate what? Pheochromocytoma. Then other management will come. Patients recorded a BP of so and so at this time. What should we do? Should we give antihypertensive? Should we give this and so? Should we give this and so? You give this. Then you start selecting them. Okay, give this. Don't give this. Reduce this. Give nitroprusside. Give beta blockers. Don't give this. Hold this. Then the next history will come. Patient was scheduled for adrenalectomy, and then adrenal gland was removed. What condition should we start with? Then they will start linking it with what? Addison's disease. You see how they frame the case study. That is how they frame it. Okay. So you should be abreast with all these things. Okay.
So it means that with the case study, when you get the first condition wrong, your subsequent answers will all be wrong.
Very good. It's true. You are going to get them wrong. You are going to get all of them wrong. If you don't take care, you are going to get all of them wrong. Okay. So you must read the history well and pick your correct answers. Okay. All right. That is it. All right. So
will you write the adrenalectomy, or it will be there with other conditions?
it will
click?
be there. Everything will be there.
Okay.
For you to get select. Okay. You're not going to. You don't write anything unless maybe it's a calculation. That is what I'm going to write. But as a calculation, you don't write anything. Okay. You don't write anything. All right. So I think some of these questions we have to find time and then answer all of them, right? Usually we answer these questions a lot in discussions. And then the case study questions, we usually try to go over them. Somehow they are well framed in discussions. Okay. So when you are in discussions, you have a feel of them very well. Okay. All right. So let's try and do our best. Okay. It is well. Okay, it is well. Be encouraged once again. Okay. I always close my class with an encouragement. Be encouraged once again. Okay. Just within this week, we recorded 3 NCLEX passes. Okay. Yes, 3 NCLEX passes just this week. So it should be informing that the goal is well achievable or highly achievable. NCLEX is not beyond anyone here. Kindly relax, please. Don't put any pressure on yourself. Just that you have to put in more effort. That one is a fact. Sacrifice your time, put in more effort, but then don't be under any other high pressure, anxiety. The anxiety will come back, control it, okay? To the point that you can't learn. No, relax. Do it bit by bit, according to your own plan, your own timing, your own strength. Just follow it like that, okay? At the end of it all, we shall all be crowned with our license, okay? All right, so
Amen.
all the best, all of us, okay? We shall meet
Amen.
tomorrow.
Thank you.